أهلا بيكم. Today we will start talking about the inside of the skull, the cranial cavity, the bony features, the meninges, and the brain and brainstem. So let's begin. Uh, After we have concluded the neck and concluded the head structures present outside the cranial cavity, I think it's time to have a look on the lymphatic drainage of the head and neck, as I promised before. You see, it's very simple. Lymph nodes thrown into two groups: superficial group and deep cervical group. The superficial group forms a ring around the circumference of the head, draining the corresponding parts, like, for example, the submental, the submandibular, the parotid lymph nodes, the mastoid and occipital lymph nodes, forming a ring around the head to drain it. And the deep group actually along the course of the internal jugular vein, as you can see here, multiple lymph nodes. So they divide them into two groups. Superior group near the digastric, so they are called the jugulo-digastric lymph nodes, and inferior group near the omohyoid, so they're called jugulo-omohyoid lymph nodes. So these are the deep cervical lymph nodes, together with a few lymph nodes pretracheal, paratracheal, and retropharyngeal. Remember those when we studied the larynx and pharynx, considered as part of the deep cervical lymph nodes, and we studied individual lymph drainage with every organ we studied in the head. So that's it for the lymphatics of the head and neck. Okay, now we're dealing with the skull. Remember, we discussed the bony face when we studied the face musculature. Remember the nasal bones. We studied the orbit with the eye and the oral cavity as well, the upper and lower jaws. Remember the foramina, the supraorbital, infraorbital, and mental foramen and what passes through them. And at the side, the zygomatic bone with its processes, the frontal, the temporal, and the orbital processes. Which is the cheekbone, and at the sides with the temporal and infratemporal fossa, we studied extra features of the skull, like the temporal lines, the superior and inferior temporal lines, the coronal suture that separates that unites the frontal bone with the two parietal bones. See the coronal suture here, the frontal bone with the two parietal bones. Observe the parietal eminence on each parietal bone, and in black races you have extra suture here in the middle of the frontal bone. It's called the frontal suture. Okay, so there are racial differences. This is the coronal, this is the sagittal suture. Any section in the body parallel to the coronal section called coronal section. Coronal suture, called coronal section. Anything parallel with the sagittal is called sagittal, and with the sagittal on the sides is called parasagittal section. Sagittal section and parasagittal sections. Observe the pterion, the one we talked about, the meeting of the sutures of the frontal, the parietal, the temporal, and the greater wing of sphenoid, and its connection to the middle anterior branch of the middle meningeal artery, or the middle meningeal artery itself, and a point with the same features mean union of sutures, like the lambdoid suture and the suture between the parietal and mastoid part. This is called the asterion. So this is the pterion and this is the asterion. Okay, recall the mastoid, squamous, tympanic, and petrous parts of the temporal bone, and as you can see here, this is the superior nuchal line that passes through the external occipital protuberance, the first bony or the last bony prominence you feel from your head on the back of your neck, the external occipital protuberance. Okay, this is a posterior view. See, this is the sagittal suture. This is the lambdoid suture between the squamous part of the occipital bone and the two parietal bones. See that? Okay, superior nuchal line is evident here. This is the protuberance. And there's another line beneath it called the inferior nuchal line that gives attachment, remember, to the muscles of the suboccipital triangle. Now, in the newly born, and during the first year and a half, the baby's skull, the sutures did not unite yet, and the bones of the calvaria, doctors, they develop only in membrane. So even they are called membranous bones, classified as membranous bones, they develop in membrane. So when injury develops in the skull, the piece of bone to be taken, like for example during a trifine operation, cannot be replaced by the same piece, must be replaced by a prosthetic, because it will not grow again. A membrane will grow instead. Okay, now this is a continuation of the normal process of closure of fontanelles. See, the baby, the newly born, has fontanelles in his head. This is the sphenoid. Fontanelle corresponds to the pterion. This is the mastoid, corresponds to the asterion region. This one, the frontal fontanelle, there is an occipital fontanelle at the back to allow for the brain to grow in size. But once they closed, there is no healing of fractured bone of this area by bone. It's only healing by membrane. That's why they are classified as membranous bones. But the bones of the skull, by the way, are not membranous. They can heal if fractured because they were cartilaginous in origin. Okay? This is the inside of the skull, the cranial cavity. This is the vault from the inside. As you can see, the marks of the reflection of the dura mater to form the falx cerebri. And between the reflections, there is the space for the superior sagittal sinus. It was here, superior sagittal sinus, one of the dural venous sinuses. And observe these impressions at the side of the superior sagittal sinus. These are done by the arachnoid granulations in the lakes, the lakes that are connected to the superior sagittal sinus for the drainage of the CSF. Okay, because CSF eventually empties into venous blood. Now, from the inside, it feels like as if you are on a series of stairs. See, 1, 2, 3. You are going down from front backwards. These are the cranial fossae. This is the anterior cranial fossa. This is the middle cranial fossa. And this is the posterior cranial fossa. If the anterior cranial fossa accommodates the frontal lobe of the brain, and the middle cranial fossa accommodates the temporal lobes of the brain, temporal lobe this side and this side. So the posterior cranial fossa accommodates what? Don't fall into this trap. Don't say occipital lobe of the brain. No. It accommodates the cerebellum. So the anterior cranial fossa accommodates the frontal lobe, the middle cranial fossa accommodates the temporal lobe, and the posterior cranial fossa accommodates the cerebellum. Okay? Now look at this, the anterior cranial fossa. The floor have ridges. This is the roof of the orbit, actually. And this is the cribriform plate of ethmoid. Remember this with the nasal cavity. with crista galli in the middle for the attachment of the falx cerebri. It's connected backward to the lesser wing of sphenoid. See, this is the lesser wing of sphenoid with its anterior clinoid processes and optic foramen. This is the optic foramen. And this is the anterior clinoid process. Now, the internal carotid artery will curve upwards and backwards medial to the anterior clinoid to be able to give the ophthalmic through the optic foramen. And this depression is called the diaphragma, the sella turcica, or the hypophyseal fossa, the fossa for the pituitary gland. Hypophyseal fossa, it's on the body of the sphenoid. This is called the dorsum celli with its two posterior clinoid processes, and this is the area of the clivus that belongs to the occipital bone. Remember, I told you about the clivus when we were describing the course of the abducent nerve, going anterior under the dura of the clivus and then enters the cavernous sinus. This is the clivus, posterior to the dorsum of the sella turcica. What else do we have? In the middle cranial fossa, we have the superior orbital fissure. Note that the inferior orbital fissure does not open to the cranial cavity. It opens to exactly the infratemporal fossa. Does not open to the inside of the cranial cavity. Only the superior orbital fissure does. What else in the middle cranial fossa? Formed primarily by the greater wing and the temporal bone. Within the area of the greater wing, you can see the foramen rotundum. This is rotundum. This is foramen ovale. This is foramen spinosum. Okay? And you know a structure is passing through these foramina. Now this is the foramen lacerum, and this is the site of emergence of the internal carotid artery to pass over the foramen lacerum and enters the cavernous sinus beside the pituitary gland, and then curves up and backwards to give the anterior and middle cerebral arteries. This is the petrous part of the temporal bone, and between it and the squamous part of the occipital bone we have the jugular foramen. See, this is the jugular foramen, through which passes 9, 10, 11 and internal jugular vein, right? And don't forget the hypoglossal canal and the occipital condyles. See, these are the hypoglossal canals for the hypoglossal nerve. And this is the internal acoustic meatus. This is the internal acoustic meatus. Tegmen tympani on the petrous part to cover the middle ear. See? So this is the posterior cranial fossa. This is the middle cranial fossa. This is the anterior cranial fossa. And at the sides you will see impressions of the middle meningeal artery mostly, because it's the one mostly supplies. See, these are the branches of the middle meningeal artery. It's the major branch that supplies the dura. Okay, this is the inferior part of the skull. See, this is the squamous part of the occipital bone. This is the basilar part and the occipital condyles, and the foramen magnum within the bone. Of course, what passes here? The medulla oblongata to become the spinal cord. Okay? Okay, see the petrosphenoid fissure. This fissure accommodates the cartilaginous part of the pharyngotympanic tube, exactly, petrosphenoid fissure, and laterally the petrosquamous or petrotympanic fissure that was for the chorda tympani. Excellent. This is the foramen lacerum. It's usually covered during life with cartilage, and this is the carotid foramen, in which the carotid artery, internal carotid artery, will enter the bone, run anterior and inferior to the middle ear, and emerges from the inside, as I told you its story in the cavernous sinus. Okay, now these are the choanae and the posterior nasal spine, the palatine bone, and the the horizontal plates of the maxillae forming the roof of the oral cavity. We have the medial and lateral pterygoid plates. Yes, and this is the hamulus, which is the tip of the medial pterygoid plate. Okay, so now after we studied individual regions in the head and neck, it's easy to identify the structures of the features of the skull. From the outside, this is called norma bisalis externa, and from the inside, which is norma bisalis interna, this one. Okay? Okay. Now, when you remove the bone, by the way, is formed of two plates of compact bone, and between them is cancellous bone, and you will find some lacunae of blood. This is called the diplo of the skull. Diplo, two compact layers sandwiching a cancellous layer. This is called, see the cut section like a sandwich. Now, when you remove the bone, you will encounter the meninges, dura, arachnoid, and pia mater. The dura mater you will was described as having two layers. The outer layer is the periosteum of the skull bone, actually, so it goes with the skull on the outer side as well through foramina. This is the endocranium, actually, the periosteum on the skull bone. And the other layer is called the meningeal layer, the one you see here. This is the one that covers the brain and continues on the spinal cord to cover it, spinal meninges, or the spinal dura. This is the meningeal layer, and as you can see, the impressions of the meningeal vessels on the dura. Now, the dura, the meningeal layer, sends folds in some areas to divide the cranial cavity into partitions, like the falx cerebri, tentorium cerebelli, diaphragma celli, and falx cerebelli. We will study these now. See, the first one is the falx cerebri. This vertical fold, see, from the dura, and between the folds, high up at the inside of the skull, is the superior sagittal sinus. It's attached anterior to crista galli in the anterior cranial fossa, and goes posteriorly to attach to the roof of the tentorium cerebelli. It has a free border, see, and attached border, which is the upper border to the inside of the skull. This is the falx cerebri. It occupies the interhemispheric fissure. Okay, between the two hemispheres. Another one is the tentorium cerebelli. Tentorium cerebelli is a horizontal fold that covers and separates the cerebellum from the brain. The outer margin is attached to the inside of the occipital bone along the course of the transverse sinus, okay, and laterally attached to the petrous part of the temporal bone, and goes with it to the anterior and posterior clinoid processes. It has an anterior free border, as you can see here. With the other border, they form the tentorial notch through which the brain stem goes down. Okay? This is the tentorium cerebelli. Remember the tentorial notch and that it has a free border. The falx cerebelli is below the level of the internal occipital protuberance. It's the same principle as the falx cerebri. It has a free border, but it's very small, very tiny, between the two cerebellar hemispheres. And the diaphragma celli, you see this region, this is the region of the sella turcica we talked about, covered with dura. See here? Covered with dura. This is the internal carotid artery giving the ophthalmic, see? And this is the optic nerve emerging from the optic canal. Oriented now? This is the fold of dura I'm talking about, which is called the diaphragma celli, that separates the pituitary gland from the from the brain, from the hypothalamus actually, and there's a hole in the middle to allow for the passage of the pituitary stalk that physically connects the pituitary to the hypothalamus. Okay, this is called the diaphragma cilia, another transverse or horizontal folds. So we have two horizontal folds, diaphragma cilia, tentorium cerebelli, two vertical folds, the falx cerebri and falx cerebelli. It's very easy. The arterial supply, we said the major branch is the middle meningeal artery that enters through the foramen spinosum, and at the level of the pterineum it divides into anterior vertical branch and posterior oblique branch to supply most of the dura actually. And we talked about when it's injured it will leak slowly, so we must detain the patient who passed out for a few seconds, even after a blow to the head. Detain him in the hospital for 24 hours under observation in case we suspect a tear in the middle meningeal vessels. Now the anterior part, remember the anterior ethmoid artery gives branches, anterior meningeal. The accessory meningeal also takes a share. The posterior meningeals are coming from the terminal branches of the ascending pharyngeal of the external carotid artery. See how long that artery is? We've been mentioning him for many lectures. Now it ended by passing through the jugular foramen, mainly to supply the dura as posterior meningeal branches. Okay, the innervation, it has a different story. Also the anterior ethmoidal nerve, but observe that the anterior ethmoidal nerve has an anterior branch that supplies the lower part of the falx cerebri, the floor of the anterior cranial fossa, and sends a posterior branch that supplies the rest of the falx cerebri backwards, see, and the tentorium cerebelli. So all this by the posterior branch of the anterior ethmoidal. So this is totally different than the arterial supply. Anterior ethmoidal supplies the mucosa of the anterior cranial fossa, the falx cerebri, and the tentorium cerebelli. Okay? Now we are left up with the mucosa of the middle and posterior cranial fossae. The middle cranial fossa, the medial part of the floor, is taken up by the maxillary nerve, while the lateral part of the floor is taken up by the mandibular nerve. Okay? And the posterior cranial fossa, the first three cervical nerves, they send branches through the foramen magnum and jugular foramen to supply the dura of the posterior cranial fossa. Vagus shares the supply as well. Okay? So you have a totally different map here. This is all the anterior ethmoidal. This is the maxillary, mandibular, and the first cervical nerves, 1, 2, 3, plus the vagus for the posterior cranial fossa. Okay, this regarding the innervation. We have the after the dura we have the arachnoid matter. It's a thin layer, avascular, and underneath it is filled with CSF and runs the vessels. As you can see here, the membrane is intact. It's in this specimen. It's translucent and does not go with the sulci and gyri. See, it bridges the sulci and gyri. Does not go through fissures except for the interhemispheric fissure. The pia is the one that actually belongs to the brain itself. It's the epineurium of the brain tissue. Spaces present in the during this arrangement, we have an extradural space in which the middle meningeal artery is. Subdural space between the dura and arachnoid. And if you find a hematoma in this space, it indicates the source, which is the superolateral cerebral veins. These will be the source of the hemorrhage in the subdural space, because they pierce the arachnoid, okay, and they traverse the subdural space to open into the superior sagittal sinus. They are liable to be torn when the brain shrinks in size a little with age. This is what happens. A subdural hematoma case in an old person who fell and hit his head against the sink. Okay, and imagine the symptoms appear after 2 years of the impact, so it's a long history. The subdural space, the subarachnoid space, the one where the vessels are, and the common source of hemorrhage, this is the stroke we know about. It's from the striate branches of the middle cerebral artery in the lateral ventricle. And then the CSF will be stained with blood, and when you take a specimen, you will identify a tinge of blood in the CSF in the subarachnoid hemorrhage. We said normally it contains the CSF and contains the vessels. It's produced by the choroid plexus in the ventricles, a modified part of the mucosa lining with lots of blood vessels in it, and secretes the CSF, and drained by the arachnoid villi that form arachnoid granulations at the top to drain into the superior sagittal sinus. Arachnoid granulations for drainage, and the choroid plexus for production. Anything that affects drainage, blocks drainage, or increased production, like a tumor, increases the pressure of the CSF inside. Okay, it's produced in the ventricles by the tila choroidici, the choroid plexus, the red structure here, fills the lateral ventricles. These are the lateral ventricles here, separated by interventricular septum, the septum pellucidum. Through this foramen, the foramen of Monro, interventricular foramen of Monro, the two lateral ventricles fill the third ventricle. The third ventricle is the area between this thalamus and the thalamus of the other side. This is the third ventricle, okay? So we have two lateral ventricles through the interventricular foramen of Monro. This is the third ventricle. And then through the midbrain, through this aqueduct of Sylvius. See, this is the aqueduct of Sylvius to fill the fourth ventricle. This is the fourth ventricle between the back of the pons and medulla, and it's roofed by the cerebellum, as you can see here. This is the superior and inferior medullary vela forming the roof of the fourth ventricle. So how it goes: fills the two lateral ventricles, foramen of Monro to the third ventricle, aqueduct of Sylvius to the fourth ventricle, and from there a central canal in the spinal cord is the foramen of Magendie, and two lateral canals, lateral apertures at the sides, foramina of Luschka, to fill outside the spinal cord and outside the brain as well. So if you think about it, the brain is actually floating because it has fluid on the inside and fluid on the outside. This is a piece of engineering, doctors. Why? The brain weighs from 1.5 to 2.5 kilograms, being heavier and larger in males than females. And it's jelly-like material. When you put it on a bench, it collapses, right? So the brain here in the skull is being put on the base of the skull, but it doesn't collapse. It maintains its shape by only the action of around 150 milliliters of CSF produced in the CNS. That makes the brain floats. They measured the weight on the base of the skull with an electrode, and it recorded 150 grams only from 1.5 to 2.5 kilograms to 150 grams only. See, it's floating. It's crucial for, yes, it's said to be the CSF, it's for the protection of the CSF, but it's not that much of a cushion. See, very thin layer, and mainly fills from the inside. The main job of the CSF is to float the brain, to make it maintain its shape. And the proof to that is if we withdraw only 5 milliliters of the CSF from lumbar puncture to examine or to introduce a drug or for any purpose, a severe headache elicits because it collapses a little. See? Okay, this is about the CSF cycle and how it's produced and drained. This would be it for this lecture, and thank you very much for watching.